Oh, sorry. Can you put it back, please? I would like to share with you about the real value of the DAIR and what does the consensus 2018 says. Thanks to Jay and Torstens that we have now this consensus. So we know that revision arthroplasty for PJI is a significant challenge to both the surgeons and patients. For the surgeons, it's quite challenging because it's quite difficult to remove a well-fixed prosthesis. It's difficult reconstructions, potentially compromise soft tissue envelopes. So the ideal end result of PJI treatments actually implant retention without infections. Why surgeons prefer DAIR? Because lower morbidity, bone-preserving procedures, reduce hospital length of stay, and it's less technical demand than 1 or 2 stage, and significant decrease in economic burdens. So if you look at this paper from Professor Parvizi, shows that DAIR still perform at relatively high rates despite an inability to consistently control infections. It's still a source of controversy, has to be done in acute post-op and acute delay infections. So if you look at the success rate, it's a lower success rate than compared to 1 or 2 stage revisions, and some predictor of lower success rates are virulence organism, symptom durations less more than 5 days up to 4 weeks. It is highly variable. This is due to the lack of consistency for definitions of an acute infections, no consecutive series, and multiple surgeons in a single study. What does the consensus say? That it has to, the rationalist has exchanged modular components about 93.3% success, performing there within 7 days after the onset. It's about 90.7% success rate, and you have to add rifampicin and combine with fluoroquinolone. Look at the results here. The vote is agree in 92%. Is there an emergency operations? No. But need to perform on an urgent basis when acute PJI patients are medically and surgical optimized. If you look again here, agree at 90-70%. Now in Holland, we have this leak study, just started last year, and we look at the nationwide randomized control trial to find the best way to treat the wound leakage. We look at the optimal timing for the DAIR. So it may be 8 to 9 days, and based on the recent PJI meeting and the usual clinical practice in Holland. And if you ask, does identification of pathogen prior to the performing DAIR help guide the surgeon's decision making? Yes, because identification is desirable, but should not promote further biofilm formations before surgery. If you look at the votes, agree 94%. So we know that the indications of DAIR are patients with an acute infections less than 3 weeks or acute hematogenous infections less than 2 weeks of onset in a well-fixed and well-positioned prosthesis, in a good soft tissue envelope, and patient with high-risk complications in more aggressive surgery. So the decision to retain implants depends on not immunocompromised patient, a PJI caused by a low virulence organism, and biofilm containment. So it's very important as well. If you look at the X-ray, usually rarely show evidence of infection. So when you do DAIR, you must have good backup of revision set. So what does the consensus say about the DAIR, about the indications? Has to be done in acute, less than 3 weeks. Because in a chronic, it will have a mature biofilm with persistent cells, can be cured only by removing the implant. If you look, agree, it's a bit less, about 80%. So it is also very important from this paper is that the click score, a relatively good preoperative risk score for DAIR failures in patients with early acute PJI. So I learned from Torsten Gerke about the technique. You have to do an aggressive debridement of all the fistulized tissue and exchange the modular components. So talking about this modular exchange, what does the consensus say? About 94% vote for agree. How about the drapes exchange? Is still unknown. About agree, about 94%. And about the instrument change pre-implant, yes, and it votes about 90%. There's some controversy when you do a DAIR. One is that is failure in DAIR affecting subsequent revisions, and how long you have to give an antibiotic. So this paper from Christopher Sherrill, who won this Chet Renawat Award, he said that fate of two-stage reimplantations after a failed DAIR, there's about 34% failure rate. But another publication from Brom in 2016, he said the failure of two-stage exchange is not increased by prior failed IND. What does this consensus say? It's no conclusive evidence. Two previous studies shows here that high failure rate of two-stage, and two more reasons shows does not increase the risk of failure of subsequent two stages, and the vote again 93%. So how many times can you do a DAIR before the two stages? The most important is resection arthroplasty should be considered after initial DAIR procedure. Again, the vote is a bit less, it's only 86%. So how long do you have to give an antibiotics? A short is 8 weeks, or long about 3 to 6 months. There's no difference between the two groups except for the high rate of polymicrobial infections in the long scheduled group. And what does this consensus say? 6 to 8 weeks of antibiotic therapy seems to be sufficient in most PJI cases treated by DAIR. Agree 91%. Besides that, it's also good we look at the DAIR in megaprosthesis and DAIR in UKA, and also in the consensus we look at the intraarticular antibiotics and how volume of irrigation solution that you might need in, and also how to treat DAIR in fungal patients. Thank you very much.